Good morning and welcome to today's webinar, Life After Transplant, Rebuilding Health and Wellbeing. I'd like to welcome our guest speakers, Melanie Moore, Teresa Garcia, Trish Joyce, and my colleague, Linda Saunders. The Leukemia Foundation acknowledges the traditional owners of the countries where we all live, study and work, and we want to acknowledge and respect their spiritual beliefs and strong connection to land, sea, culture and community, and pay deep respect to elders, both past and present, who invite us to learn about their rich culture and history. And we extend a warm welcome to all Aboriginal and Torres Strait Islander people joining us today. This seminar will be recorded and will be available on our YouTube channel and our website, so you can always go back and double check things. And there will be a brief question and answer session at the end of the presentations, so please put any questions that you have into the chat. So March is Multiple Myeloma Awareness Month, and the theme this month is a focus on you, not just your disease. Many of you here will have experience with myeloma, and it's a reminder for everyone that you are more than your diagnosis. A blood cancer diagnosis can often cast a shadow over your physical and psychological health and well-being, and feelings of loss of control and uncertainty about the future are really common and can occur at any time after transplant. You've survived, though things are not the same as they were. It can be difficult to find the right support once you've left the hospital system, especially when others comment on how well you are doing. Today, we'll hear about various aspects of learning to manage your health and rebuild your well-being after transplant. Today, our focus will be on autologous and allogeneic transplants rather than CAR T, but even though there is some information specific to these treatments, there will also be information common to the blood cancer experience. It now gives me immense pleasure to introduce our first speaker, Teresa Garcia. Teresa is an experienced cancer nurse with over 20 years of haematology experience. She's a clinical nurse consultant in the Allogeneic bone marrow transplant team and leads the long-term follow-up clinic for the bone marrow service at Peter MacCallum Cancer Centre and Royal Melbourne Hospitals. Teresa completed a Masters of Cancer and Haematology Nursing at the University of Sydney and has been a co-investigator on several research projects, including psychosexual interventions for couples after allogeneic bone marrow transplant and facilitators and barriers for adolescent and young adult patients transitioning into the adult long-term follow-up care. Teresa has presented in many forums, including staff education and conferences on topics including cardiac dysfunction, psychosexual health, and late effects in allogeneic bone marrow transplant. Her favourite role is Mum of Louis, who challenges her every day with his very clever and insightful questions. Thanks, Teresa.
Thank you, Jane. Thank you very much. I'm just gonna share my slides. Good morning, everyone. So yeah, thanks, Jane, for that wonderful introduction. So I am the nurse consultant for the long-term follow-up service at Royal Melbourne Hospital and Peter MacCallum Cancer Centre. So I'd like to start. Oh, it's not working. Sorry.
You can just arrow across.
Yeah. Yeah, it's not working. Sorry, I don't know why.
There we go.
So, sorry about the delay. So allo-BMT survivorship starts from the day of referral. So thinking about survivorship from the very beginning is really important. This is where both the healthcare providers and the patients and their care should start to think about what it means and integrating the concept of survivorship earlier on in the transplant phase. More than 60,000 bone marrow transplants are performed every year globally, and the use to treat various conditions is considerably expanding. Literature shows that the number of BMT survivors are predicted to increase by 5-fold in 2030, and that patients are living beyond 2 years of post-their transplant. Literature also says that people who are alive and disease-free at 2 years post-BMT have the chances of being alive in 10 years post-BMT is over 80%. However, BMT survivors are at variable risk of developing late effects, and that depends on their diagnosis, the prior treatment, the type of BMT, as well as the personal and family history and lifestyle behaviors. So in long-term follow-up, we look at all the aspects and all the treatment that the patient has received, not just focusing on BMT itself. So these are the literatures that shows that. One of the CNCs in the AlloBMT group, I've adapted this diagram from her. This just talks about like the allograft in the bigger picture. So day 0 is when we receive, or you receive the stem cells. And then as early as day 100 or up to 1 year, there's like early complications that can be associated with it. And there are also the late complications, such as chronic graft-versus-host disease, that can also happen from 2 years and beyond. So in our service, we try and assist in the care coordination to hopefully help manage late complications that may arise over the years. As what I've mentioned earlier, survivorship considerations and discussions with patients should begin early in the treatment pathway. Survivorship is an overarching principle that incorporates the early, the mid, and the long-term care after treatment for cancer. So it is a complex area that encompasses transitioning patients off the active treatment, providing support for rehabilitation and return to work, planning for disease-specific and treatment-related follow-up, and also providing psychosocial and community-based support. So survivorship does not only look at the physical aspects of care and survivorship. We look at the psychosocial, the psychosexual, and the vocational aspects of it. And I remember the LTFU service had a project a few years ago where their training incorporated training platforms have been developed for primary care physicians, upskilling them to participate in providing survivorship care for BMT survivors that can be best suited for them. And we implement that as well as part of the shared care model. Because of the innovation and the improved supportive care, more and more AlloBMT survivors are surviving beyond 2 years. This complex treatment, however, may result in physical late effects, psychological distress, and financial and employment stress. Studies also demonstrated that patients and families are not prepared for the long impact of long-term recovery. And from my experience and from what patients tell me in the clinic, some of them have mentioned that it has taken them at least 2 or 3 years, or sometimes more than 3 years, to completely feel that they have recovered from their transplant. There are also some who takes longer in terms of recovering, not just from the physical late effects that they've experienced, but also from the psychosocial aspects of it. Then there are also some patients who would come to the clinic and say that I'm feeling fine, but I still want to come because I wanted to see you and obviously have this discussion with you. And the need for focus on non-clinical complications is also very important. Just a brief overview of our cohort. So post-BMT patients who are 2 years or more post-transplant are referred to our clinic. And the referrals come from the bone marrow transplant centers across Australia. We're also receiving referrals from pediatric centers, which patients had their transplant as a child, but they are now over 18 years old, and it's transitioning to an adult long-term follow-up service. We also receive referrals from general practitioners, and some referrals we've received are from international or overseas referrals, and patients can also self-refer themselves to our clinic. This is a list of the goals of the AlloBMT LTFU service. So we focus on screening, identification, and treatment of potential and actual late effects. The screening and the treatment is based on the previous treatment or the prior therapy. It's also dependent on the type of bone marrow transplant that they have received, as well as the family and personal history. And the treatment recommendations are all community, are evidence-based, and our guidelines that we follow are both national and international guidelines. We do a lot of education and counseling. These are all related to health behaviors and helping to manage this disease risk reduction. We do a lot of self-monitoring and self-management, and we are obviously a very cautious and very important to do the community screening guidance. So, have they done the bowel cancer screening, their breast screening guidelines, and, check their skin and all that stuff. So we also do a lot of psychological support for patients, and we do referrals. We have an in-house post-BMT clinical psychologist that we refer our patients to if ever they feel the need to speak to someone. And also, they can also go to their general practitioners for a mental health care plan. We also do with fertility assessment and counseling. We know that patients are wanting to find out, if they're fertile or infertile, and then we assist them in sort of like navigating and doing the referrals to our fertility specialists. We also encourage vaccination adherence. We have a very good vaccination program at the BMT service here, where we liaise and work collaboratively with our post-BMT vaccination nurse that helps us identify if patients are due for their booster vaccinations or if they need catch-up vaccinations, particularly if they've had their transplant elsewhere, because we don't have their records with us. So our post-BMT vaccination nurse helps us identify what vaccinations they're due. And like what I've mentioned earlier, we help them identify goals and assist in navigating those goals. So in our service, we send them out some questionnaires, and part of that questionnaire is we encourage the patient to write down what their goals would be for the next 12 months. And we use that as part of our clinical service delivery. So we look at their goals and see how we can assist them with that. And then when they come back to see us the following year, we'd also review that and see how did they go in terms of achieving or navigating towards their goals. We also connect them with the primary care providers. We provide a survivorship care plan after our consultation with them. And this is what it looks like. So in our survivorship care plan, we have summary of recommendations that our clinic will arrange. We've got recommendations there for the GP to arrange, and we've also got some recommendations that the patient can arrange themselves, like, for example, dental follow-up or eye follow-up. And in terms of the GP, if we wanted them to repeat certain blood tests or referral to dermatology in the community or allied health, then we also incorporate that into our survivorship care plan. I just wanted to give you like a snapshot of the first visit data that we have in our long-term follow-up service. So we currently have more than 700 patients who have been referred to us, and the age range is between 18 to 74 years old. More than 50% of the patients are male, and the years post-allo-BMT is between 2 to 39 years old. And 58% or nearly 60% of them are in employment, both part-time, full-time, and casual. In terms of the disease distribution, so majority of the patients that have had transplant have been referred to us have got leukemia, followed by lymphoma, bone marrow syndrome, and there's others like X-linked disease and multiple myeloma. So what are late effects? And these picture we've adapted from Inamoto and Lee in 2017. And I think that this just encapsulates like all of the possible late effects that the patients might experience after transplant. So there's there could be endocrine diseases, late effects such as thyroid dysfunction, bone disease or like osteopenia and osteoporosis, cardiovascular late effects, neuropsychological late effects, and also some pulmonary diseases. And I know it's a lot, but I just wanted to show you that this is what we look at and assess when the patients come to our clinic. We do like a whole person approach. So out of this, I'm just going to take like a snippet or a snapshot of the things that we have identified or the patients have raised with us on the first long-term follow-up visit. So one of them is chronic graft versus host disease. I won't go into detail in terms of the chronic graft versus host disease because I feel like it's going to take a whole session just to discuss like all about chronic graft versus host disease. But I do want to point out like the common sites. So graft versus host disease can affect like other sites. The most commonly is the skin. And that's when patients would say like, oh, I've got a rash on my skin that I'm a bit concerned about. I'm not sure. It's a bit, it's a bit like a bit of redness, for example, and a bit of irritation. Or sometimes patients may say that there's a bit of thickening of the skin called the scleroderma. So we look at that and we assess that. Also part of our BM long-term follow-up service, we have a parallel clinic with dermatology once a month. So if patients would come to us and they've identified any lesion of concerns, we could do like an in-house or a walk-in referral to dermatologies. So about 6 to 8% of those patients we've identified with gut skin chronic GVHD, followed by the eyes, which is about 17% have got that like dryness of the eyes, irritation. Sometimes they would say they've got blurring of vision. So we all look into that. And that's why we also advise that they see the optometry and have eye review regularly. The other side would also be like the oral or the mouth. And sometimes patients, some of the symptoms would include like sores in the mouth, some irritation and pain. And sometimes they would say that there's like, it's kind of hard to open the mouth when they've got really, GVHD. And also the lungs, it's not a lot of it, but then obviously, so when the patients come in, we assess them and say, have you got any shortness of breath, any coughing, any symptoms? So we all do these assessments and do like referrals if needed. The other issue or concern that we've identified at the first long-term follow-up visit is bone health. So about 40% of our patients have got low bone mineral density, and over 60% of them have osteopenia, and nearly 40% have osteoporosis. I won't go into detail in terms of like managing bone health and stuff because this will be discussed by one of our speakers later on in the webinar. 23% have also diagnosed cardiovascular disease, and we've identified that about over 50% of the patients have got high cholesterol. And this is when, like I've mentioned earlier, in terms of our goals, we do a lot of education on lifestyle modifications and like diet and exercise to try and manage this sort of like conditions. Nearly 20% have been identified that have had secondary cancer at their first LTFU visit. And these are mostly skin. So, and they are the non-melanomatous skin cancers like your SCC and BCC. And some of these patients have had or have chronic graft versus host disease of the skin. So we do, as part of our review, we do a lot of secondary cancer screening. So we do thyroid ultrasounds in adults who receive radiotherapy as children. In all our patients, we do thyroid examinations and we check their thyroid function tests every year. If we've identified some abnormalities, for example, we do an endocrine referral or we'll repeat their blood test if need be. We encourage breast screening and for women over 45 years old. And if they've had radiotherapy exposure and they're 8 years post that, then we encourage breast screening as well. Bowel screening is also encouraged, and especially for patients who are 10 years post radiotherapy exposure. Prostate screening in certain groups, depending on their family, on the family history. We do encourage annual full skin check, especially for patients who have had total body irradiation as part of their conditioning therapy, or if they've had radiotherapy prior to transplant, because some of them may not have TBI as part of their conditioning before transplant, but some of them have been exposed to radiotherapy prior to that. We do oral examination and we do a dental oncology referral for any suspicious lesions. And we promote and encourage for them to do a 3 to 5 yearly cervical screening. So those are like the sort of like the physical late effects that we've identified in our clinic. It's like I mentioned earlier, survivorship care covers the psychosocial and the psychosexual aspects as well. So when we send out the surveys, we've got a distress thermometer and anxiety and depression scale that patients would fill in, and just so we know that we use it for our clinical service delivery. So in psychological distress, depression and anxiety are prevalent post-allo BMT, and it can sometimes take 2 years to plateau. The high incidence in people with chronic health burdens, particularly with chronic graft versus host disease, and as well as patients with persistent GVHD, they report that they've got some degree of anxiety as well. The other thing that contributes to that is the changes in the roles, such as employment and financial circumstances are the common stressors. So when we receive the survey, some of the patients, or when we see them in clinic, they'd comment like, they're not sure if they can go back to their work after the transplant or if they can go back full time. So those are the sort of like the things that they have in their mind. Fatigue is also another psychosocial health that I certainly have experienced and that the patients have mentioned to me. And when I looked at our data, there are about 50% of the patients have mentioned that fatigue has affected them post-transplant and is still affecting them now. And it can have an impact on the family as well. And fatigue is sort of like multifactorial. There's so many potential causes. It could be affected by the conditioning pre-transplant. It could be affected by obviously like if you've got chronic graft versus host disease or issues, or if there's lack or little sleep. And sometimes the hormone changes can also affect the fatigue as well. So when they come to our clinic, we do give them a lot of education and counseling and help in trying to help them manage fatigue, such as, doing exercises, obviously listening to your body as to how much exercise and the extent of exercise that you can do. Having like short naps or taking short breaks during the day if needed, but also trying to avoid like longer naps because that might affect the sleep at nighttime. And obviously diet is also very important. So, like or what you eat during the day, and that would help in promoting, energy, to try and manage fatigue as well. About nearly 30% of the patients have reported having a fear of worry about post transplant survivorship, and the fear mostly is about recurrence. So they say that, oh, when they experience fatigue, for example, or if they experience like they feel something on their body, there's like, oh, is that my cancer coming back? So there's still that fear of the cancer coming back, and also there's the worry, what if they develop like secondary cancer in the future. And that's why it is important that we educate them on the importance of the screening. We give them a lot of reassurance, especially if like they're reporting these symptoms with us. There's some also patients who have reported to me that they have fear or worry about, unemployment in the future. They fear that what's the future gonna be like if, for example, they can't go back to full-time work, or they won't be able to do the things that they were able to do previously. And apart from this, some patients have also reported some issues with their sexual health and sexual dysfunction, which I won't go into details because I know one of our speakers is gonna talk about sexual health. But I just wanted to highlight, I know Jane has mentioned earlier that I've been a part of this psychosexual study that was done at PITAMAC in Royal Melbourne. And I'm happy to circulate that article if you want to. So also part of the survivorship is the employment and the vacation. So as part of the data in our long-term follow-up service, we've looked at how patients are going in terms of the employment. So 93% of women and 94% of men were working or in active study at the time of their diagnosis or commencement of treatment. And on that table, you could see the age range and the percentage of that. Comparing that at their first long-term follow-up visit, 47% of women and 50% of men were working or in active study at their first long-term follow-up assessment. So this shows that the re-entry into the workforce or study is reduced by about 50% in both men and women after bone marrow transplant. And people who are over 45 years old or older are the group that's most commonly affected. And so when they come to our clinic, we look at, how we can help them navigate that in terms of their employment and then vacation, or if they're like ready to return to work, that's something that we'd also like discuss with them. Just to sum it all up, so these are the things that we do. Like I've mentioned earlier, we involve the GP to do like a shared care in terms of like providing survivorship care with our patients. Our reviews are done face to face, or it could be done via telehealth or phone review for patients who are interstate or who lives outside the metropolitan Melbourne. We do a lot of education in terms of like the diet and exercise, and also cancer screening adherence. We are helping our pediatric patients who are transitioning to adult long-term follow-up, and I get in touch with them as soon as we receive the referral. I contact them and introduce myself on the service so they know who to contact if ever they have any questions. These are my references. And with that, I'd like to thank you for listening. That's my email and the long-term clinic email if you have any questions. And I would also like to promote the Straight and Marrow podcast. So this is done by the nurses in the AlloBMT space, and it discusses all things allogeneic bone marrow transplant, from pre-transplant considerations to survivorship, using experiences of healthcare providers, patients, and carers. So thank you very much.
Great resources, Teresa. Thank you so much. And next we're going to hear from Trish Joyce. And Trish is a clinical nurse consultant who's worked in the field of haematology with a focus on myeloma and autologous transplantation for over 20 years. She has a particular interest in the development of care systems that support improved patient experiences in the outpatient setting. She also collaborates with the infectious diseases team in the delivery of post-transplant vaccination service at the Peter MacCallum Cancer Centre. Thank you, Trish.
Thank you, Jenny, and good morning, everybody. It's a real privilege to be part of this webinar today. And thank you, Teresa, for wonderful setting the scene. So as Jenny said, I'm one of the nurse consultants here at the Peter MacCallum Cancer Centre. I work in the autologous and myeloma service, and I'm going to talk generally around some of the issues that are common to our patients following an autologous stem cell transplant. So now I'm going to just share my slides. Just bear with me. And here we go. I hope. Okay. Can everybody see that? Fabulous. Okay. So we know that going through a transplant at the end of often a very, challenging induction treatment for our patients is hard work. And particularly the marathon, it feels like you're just absolutely running marathons really to get through and to get out the other end. And sometimes it's not until you're at that other end and you're trying to piece back your life again that little things come up, and sometimes they can be big things. And so really today, part of my focus is to talk about some of those issues a bit more practically and to look at ways and how we can, minimize those things from happening. So it's really the focus, there's been a real shift in the care of people that undergo an autologous stem cell transplant. And there's been a real change in the treatment landscape, particularly of myeloma, which is one of the diseases, the cancers that I are really deeply involved with in our service. And both of those things together mean our patients are having much more successful outcomes. They're having much more deeper remissions, and that those remissions are lasting longer, primarily because of the significant advances in treatment. And of course, the transplant is one of those treatments. And I think as well as that, we now know that we're very cognizant of what that experience is like for our patients after a transplant. So we've got them in a remission, they're going to stay in a long remission, but we want to make sure that they try and get back to, I guess, a new normal. It's, and that's what we learn from our patients every day, and that's what you tell us. So I think the first thing that I wanted to talk about, and the thing that I see a lot in the clinic, is a risk of infection. And even though you get through your transplant, your immune system is still recovering, and that, depending on what kind of a transplant you've had, can take, weeks to months and even into years. I'm just going to advance my slides here. So essentially, infection is a really important part of the care of somebody after a stem cell transplant. And particularly, we know that there's a couple of things going on that increases your risk of infection. One of those risks is the loss of immunity. Retained immunity from previous vaccines that you had as a little child, or, experiencing infections gives us immunity as well. All of those can be interfered with as a result of the high-dose chemotherapy. And so particularly patients after a transplant have a significant loss of immunity. And if you couple that with the treatment that we give to the patient, while we're waiting for our bone marrow to engraft and for our immune system to recover, that takes time. It's not something that happens immediately. Sure, our blood counts will come up, and that will be heralded a safe time for you to leave the ward. But there are other arms to our immune system that can take several weeks to months to fully recover after a stem cell transplant. And so in this time, a person after a transplant is more vulnerable to infections, and particularly to vaccine preventable infections. So that's why it's really important that, as Teresa said in her presentation, that we talk about vaccination, we explain and counsel people after a transplant the importance of having being revaccinated, and what we're trying to do and protect you. Have I moved on to the next slide? No, I'm still on this one here. The other point I wanted to make before I leave this slide about why infection is common following a transplant is some infections that lay dormant in our bodies can become reactivated. And that's because of our reduced immunity. Shingles is particularly one of those infections, and there are many more. Some of you might have heard of CMV, cytomegalovirus virus. So there's a number of them that can become reactivated. And we as healthcare professionals are very big, that's one of our surveillance, that's what we're monitoring. And there are medications that we can give to suppress some infections from happening. You'll all be familiar with a tablet called valganciclovir, which you would have been on during your transplant, which usually keeps going until the person's had their second and final dose of Shingrix vaccination that I'll come to in a minute. So I guess what this slide is saying is that you are immunocompromised, but there are measures that you can take to reduce your risk of getting an infection. And it's about making sure that you kind of adopt some of those strategies. Okay, I'm on my next slide. I hope everybody can see that. So this is about risk of infection in multiple myeloma. And I want you to look at the bar graph on the left particularly, and this looked at the number of cases of infections in multiple myeloma patients. It was a big population-based study, and the myeloma cases are on the left, and they compared it to control arm on the right, so patients that didn't have myeloma. And you can see that the significant increase of infections in the first year of a person's diagnosis with myeloma in comparison to the control arm, which was quite low. So we know that the treatment we give for our myeloma patients particularly, it increases and makes them more vulnerable to infections. And there are particular times during their treatment journey as well that your risk will be slightly higher than others, and particularly that's after a during a stem cell transplant and afterwards. So again, I guess the point of putting that slide up is to really highlight, yes, we have the evidence. We know infection is a significant issue for our patients, particularly during a transplant, but also in that first year after a stem cell transplant as well. You can be more susceptible, particularly to viral infections. So bacterial infections are more common around that 2 to 3 week stay in hospital, but when you get out in the months after a transplant, it's more viral infections. Okay. Now, if you put myeloma aside, and if you think of just the general population, and we know that the burden here in Australia, this is taken from the Australian Institute of Health and Welfare, that the burden of vaccine-preventable diseases in Australia increases as we age and as we get older. We know as well that we've got an aging society. We're all getting older. So we need to have a think about that for us as a society. And you can see in that slide that the incidence of influenza zoster, which refers to shingles, and invasive pneumococcal disease, which is caused by pneumococcus bacteria, are significant issues for people in the over 65-year-old age group. So we're mindful that now in the mid-2020s, that doing a stem cell transplant for somebody in their early to mid-70s is quite a common thing to do. And so for that age group, we particularly need to be more cognizant of, the importance of discussing vaccination, making sure their vaccines are up to date, letting them know about any new vaccines that come onto the market that could be, important for their care as well. So I think, vaccination and infection prevention strategies are a very, important part of keeping a person as well as we can after a stem cell transplant. So infection prevention strategies involve very simple things that we can all adopt and we've all grown accustomed to during the COVID pandemic. But mask wearing at particular times during a person's treatment and recovery after transplant is important. Particularly, I say to patients, at least in that first 4 weeks, after you leave the ward, be mindful to avoid big crowds. If you have to and you need to go out, making sure you put an N95 mask on, good hand hygiene. All of these things are really important strategies to help keep you well and healthy. I think as well, because, some of you may not be ready to have your vaccines yet. Sometimes there's a delay and your doctor might advise to hold for a period of time, depending on where your blood counts are at. I think that knowing, that's the advice if that's what your doctor has told you at the time. But, you can be proactive as well, so that if you do get any viral symptoms such as a runny nose, a cough, sore throat, importance of early testing is really important, so that if you are positive for influenza, for COVID and RSV. So RSV is a viral infection predominantly around in the winter months. It's respiratory syncytial virus infection and is a respiratory. So COVID, flu and RSV, they're all respiratory infections and particularly can peak as well during the winter months. So I think prompt testing is really important, and that's what we encourage our patients to do, to communicate with your primary team, because if you are positive for COVID, then we can initiate early intervention with antiviral medication to reduce the infection burden on you and to help you with a quicker and faster recovery from the infection. And also for influenza, there's oseltamivir is an antiviral medication that we can give as long as you're identified and you picked up early enough in your in the course of the infection. So these are things you can do in the meantime while you're waiting for getting your vaccines on board. And now the self-testing kits that you can buy in the chemist include influenza, RSV, and COVID. And it's good to have some of those at home, in your cupboard, in the event if you do, develop symptoms. And I think when you're ready then to have your vaccines, I think it's really important to communicate either with your primary transplant center or your team that's looking after you. Your vaccinations, which I'll talk about in a minute, may be done through your GP, or it may be actually your hospital and your transplant, where you had your transplant, who will take over that responsibility and facilitate that for you. I think, though, it's really important that you consider everybody else that's living with you at home. And a really good strategy as well to reduce your risk is to make sure all of the individuals and all of your family members, where possible, can get their flu shot and also be up to date with their COVID vaccinations as well. And I think that's really sensible, because it's just, trying to reduce the risk of transmitting the infection to you if they did get it. Next slide. So this is a fairly typical vaccination schedule. I hope you can see it. And this is the vaccination schedule that we recommend to patients after an autologous stem cell transplant, and allogeneic transplant are basically exactly the same. And so your treating center would talk you through this. Typically, we wouldn't initiate this until you're around about 6 months after your transplant. And the rationale for that is we want you to have some immune reconstitution and recovery. because we want you to be able to mount an antibody response to the vaccines that we're giving. If your immune recovery is still suppressed a little bit, we might decide to delay it. And there can be lots of variation, reasons for that. Typically, though, after an autologous stem cell transplant, we would start at around about 6 months. And that's usually a ballpark figure where people are ready. Often for myeloma patients, they sometimes will need a further couple of cycles of treatment even after their transplant, and then head into some maintenance treatment. And so that 6-month mark is a kind of a nice mark to meet the patient where they're ready at that stage. Usually at the 6 months, they've finished the other 2 cycles and then they're ready to start. And quite a lot of our patients are on their maintenance treatment for their management of their myeloma as they go through their vaccination schedule. And there's no contraindication at all where that's concerned. I think the important thing is there's the whole page of infectious diseases that you will see there. And some of you might say, hey, I don't think I've ever been vaccinated against any of those, which, might be the case. But the main ones that we get, is Haemophilus influenza, meningococcal infection, and pneumococcal. So they're the kind of 3 major infections. Then the influenza, COVID, you can do earlier than the 6-month mark. We're coming up to winter now. So any of, a lot of you on the call really should be starting to think about checking in with your GP, booking yourself in for your flu vaccination, checking to make sure your COVID vaccination is up to date. And ATAGI, we get a lot of our advice in terms of vaccinations from ATAGI, which is the central body of trust when it comes to the knowledge and the expertise around this guidance. And so basically, COVID vaccination, what's recommended is a yearly booster, and anybody over 75 really could consider it. They would recommend every 6 months. There's good evidence now as well in the study we did here at Peter Mac under Professor Benjamin Tay and authors. They recommended 2 doses of the influenza vaccination in the first year after the transplant, but then after that it's just yearly. So it's really, the evidence is just for the 2 doses 4 weeks apart, really in that first year after the transplant. And then, of course, depending on what your age group is, there will be adjuvanted influenza vaccination. So basically, for people over the age of 65 and above, they're eligible for the adjuvanted one, which is designed for people whose immune system may be a little bit more, may need a little bit more sort of stimulation to mount a response. So that's a typical vaccination program. It seems a bit long and wieldy, and usually it's done on a monthly basis. The most important thing is that all of the vaccines that we give are non-live vaccines, and really no person should have a live vaccine after a transplant until they've reached 2 years after their transplant. And that's because of the risk of an adverse reaction or causing infection if they did. So that's really important. And that's all part of the counselling discussion that you would have with your doctor and your treating team, and also your GP as well. So I'm just going to move on to the next slide. So you would have seen on the list of vaccinations that shingles is one of those infections that can become reactivated. So pretty much the majority of society has been exposed to chickenpox by the time they've reached their adult years, and that virus stays dormant along our nerve endings. As we get older, our immune system gets weaker and tighter, and particularly often you hear in the community that people in their late 70s and 80s and 90s can get shingles, which is the reactivation of the chickenpox virus because their immune surveillance has declined. Similarly, after a transplant, the experience is the same. So that's why we recommend the valacyclovir. And it's really only been in the last couple of years that we have this new vaccination for shingles, which is a non-live one, which is great, because prior to that, we only had a live vaccine that we couldn't give to our patients after a transplant. So Shingrix is something that is available to all of you. There shouldn't be any cost involved for you to get the shingles vaccine. It's given on a two-dose schedule, usually 2 months apart. And usually our advice is once you've had the second dose, the majority of people can stop their valacyclovir. So shingles is very painful. It's, it's something for you to be aware of. If you get any unusual rash that shows signs of blisters and is painful, you need to see your GP straight away. Get a swab done, your GP, and your GP then would start you on some antiviral treatment for it. But with the Shingrix vaccination, and like any vaccine, it's not going to 100% protect you against shingles, but hopefully will reduce the impact of the infection if you did get it. So that's a new vaccine that's now been in clinical practice and available, on PBS and for GPs in the general society as well. So COVID infection we've talked a little bit about, but it's still very much out there. It seems to wax and wane, right? Often typically it's, pre-winter and then in November, December. So it continuously goes along. And it's kind of aseasonal. It doesn't really matter if it's winter or non-winter. So it's still out there. It's still a significant infection. We need to be aware of it. We need to, counsel our patients to say, look, it's really important. This is why we're wanting to reduce it. This is why we're recommending it to you. And ATACI recommends revaccination irrespective of the amount of doses you've had pre-transplant. And I want to get you away from thinking about how many number of COVID vaccines you've had. You have to think of it a little bit like influenza. So we recommend a 2-dose schedule, usually starting at about 3 months after a person's autograft, and then a second dose maybe 2 to 3 months later. There will be slight variations in that, depending on the age of the person, and you have to take into account, if they've had recent COVID infection and things like that. But, it's important to keep it up yearly, and particularly for our older cohort of patients over the age of 75, we would recommend every 6 months.
Trish, excuse me.
Sorry,
we're just getting close to time, so just letting you know.
Okay,
a couple
sorry,
minutes.
Linda.
Sorry.
Yeah. So influenza, we might consider it as not a very significant infection, but it is the stats there speak for themselves. So really, really important to get that vaccine under your belt. Travel health, again, it's really in the vaccine clinic that I work with here at Peter Mac with one of the other infectious diseases physicians. Travel health comes up, and of course, it's a time in your life when you're getting through, you're feeling stronger, you're feeling more confident, you're thinking, hey, I'm going to start thinking about, planning a trip. I think it's really important to have a think about in advance and spend some time on your travel health, having a think about discussing it with your doctor, making sure your medications are okay, making sure your hematologist, has no concerns, and also having a think about perhaps seeing a travel health doctor. Usually I would wait until about 6 to 12 months once to make sure the bulk of your vaccination schedule. But one point I do want to make on that slide is to think about a measles blood test. Measles is starting to re-emerge, and not just in Australia in a big way, particularly in North America and, of course, other countries in Southeast Asia. So I think we need to be very vigilant of it. You need to make sure you have a blood test done. You need to know what your status is and what your immunity is before you travel. So I guess in the interest of time, I might start to wind up. But I think preventative healthcare is something that's really important now, particularly in the myeloma space, particularly as our patients are getting those deeper remissions. Like Teresa spoke in her presentation, it's important to make sure that we're looking after other parts of your care. And particularly that's because we do know that the evidence tells us the risk of cardiovascular disease and the risk of infection and the risk of getting a secondary primary malignancy is slightly higher in people surviving and living after a transplant. And so this slide just speaks to that about, these are, a big study of, greater than 3,000 patients. And you can see that the long-term events related to cardiac issues are not insignificant, around about 13% at 5 years in the transplant population. So that's why it's really important that we think about follow-up care and preventative health care. And that's a major change that I am experiencing as a clinician working in this field. And it's about having those discussions about your screening. And here at Peter Mac, we have introduced a similar clinic to Teresa, but a little bit different as well. It involves a 12-month review with one of our clinical nurse consultants to make sure all of the recommended screening tests are underway, to make sure you're adopting a healthy lifestyle, working with you to look at ways that we can reduce or modify your cardiovascular risk factors, if indeed you have any, looking at your bone health and making sure all those preventative strategies are underway, as well as your vaccines and monitoring for any symptoms you might have developed during your treatment. Sexual health, I don't know if I have time to go through this one, Linda, but it's a really, really important part of your health, particularly as you start to, return and feeling more stronger in yourself, more confident in yourself. And it's something that we need to really address. And we have, again, like Teresa, in our follow-up clinic, we've incorporated that as a very important part of a person's healthcare after their transplant. Sexuality and sexual health related issues often don't get the due, recognition or input from from your medical review clinic. And often your clinic reviews are so full of all other questions. So in this clinic, it's about sitting down and having time to look through and address some of those issues. And for some of you, there won't be any issues, but for many, we know that the evidence tells us, and the literature out there, we know that, menopausal symptoms, vaginal dryness, loss of libido, these are all reasonably common, sexuality or sexual health issues for us after the treatment that we've done. So I think it's really important. I think the first step is talking to your healthcare clinician. You identify one person in your team, and we've kind of put it in this clinic format in the follow-up clinic. But what I would say to you is that it's something that should be raised and discussed with your either doctor or your nurse specialist at your treating centre, or even your GP. GPs are a wonderful resource of information and knowledge and expertise as well. And there's lots of resources and management strategies that we can put in place for you. So I've talked about here at Peter Mac, we have a special clinic that looks at sexual health in our urology clinic. Particularly erectile dysfunction is a very common, reasonably common, I should say, side effect after the treatment. So there's lots of strategies, I would say, out there, and it's important to raise it and communicate it with your team and get your questions and your concerns answered. So on that note, I might stop, and I apologize for going over, Linda, and I'll stop sharing.
Thanks, Trish. This is clearly a huge topic, and I think maybe we've tried to cram too much into a short time. Our third speaker, and I'm delighted to introduce her, is Melanie Moore. Melanie is an experienced clinical exercise physiologist and a researcher, and she specialises in the role of exercise from a cancer diagnosis through to recovery. And with over 15 years of expertise in clinical leadership and supportive care, she leads the University of Canberra's student-led Exercise Physiology and Wellness Clinic, which provides evidence-based programs for people affected by cancer and the associated chronic health conditions. So her passion for improving post-transplant recovery stems from her own experience with blood cancer and transplant, and it drives her commitment to research and advocacy. She's currently pursuing a PhD through Flinders University, focused on exercise prescription and recommendations for individuals affected by blood cancer, with the aim of translating this into clinical practice. She's dedicated to empowering people undergoing a stem cell transplant, both auto and allo, and to safely integrate individually tailored exercise before, during, and after treatment to support recovery and well-being. Thank you, Mel.
Morning, thank you. Can you all hear me now?
Yeah.
Excellent, thank you. So today I will be talking about exercise for recovery to help rebuild your health and well-being following a transplant. I will be discussing the benefits of exercise and also some recommendations that we do need to follow to help with that recovery, as well as the precautions that we should be taking to ensure that we do have a safe return to exercise. So just a little bit about my journey. So I did undergo a stem cell transplant back in 2015. It was an allogeneic, it was a matched unrelated donor, and he was actually from Poland. I did move from a O positive to a B negative blood type group, and it did take quite a little bit of time for me to engraft. So it took about 9 months, and I was supported by blood transfusions during that time. When it came to my journey, I did apply my professional knowledge into practice. I've worked as an exercise physiologist prior to my diagnosis, and I worked with individuals who were undergoing cancer treatment and post-cancer treatment. And so I really had to put my money where my mouth was. I knew that in theory, exercise helped with reducing fatigue levels, but I really had to ensure that I actually saw if that was possible. I made sure that I controlled the modifiable risk factors that I could during my process, and that's where I implemented exercise, nutrition, and lifestyle factors, as well as mindfulness strategies. And so I've done this ever since before transplant, during transplant, and even into recovery. And every year I consider my transplant anniversary as my butterfly day. And that's because on the day that I had my transplant, my sister saw butterflies everywhere. And so that is how it was considered my transplant anniversary. Sorry, I just realized my camera was off, so let me just put that back on. So what's really important is that we take each day as it comes and we try to restore our function as best as we can. And that's why we look at well-being. When we're looking at well-being, we're looking at the state of ensuring that you can actually thrive during the process into recovery. And when we're looking about navigating the process of recovery, as both Therese and Trish has mentioned, that it does take time. Everyone is individualized, and it does depend on your age as well as your physical function, as well as other factors. But the underpinning factors that we look at is not just medical. We're looking at your physical, your psychological, as well as your social well-being. So when it comes to your recovery, we know one size does not fit all, and we want to make sure that we're addressing the person as a whole. And that's where collaborative care is really important. You have not only your treating team, but you should also have a supportive care team, which includes, hopefully it includes an exercise physiologist or a physiotherapist, a dietitian or a nutritionist, as well as someone to support your mental well-being, like a counselor or a psychologist. Because we know that when we actually integrate these modalities, we actually have a more positive outcome rather than if we're only focusing on one aspect, because we're looking at the whole person. And this is where we look at the fundamentals of recovery. So when it comes to the benefits of exercise, there are a lot of different benefits depending on where we are within our treatment, whether it's before, during, or after. With being post-treatment, there's obviously factors that what we're trying to address. And a lot of time it's rebuilding, restoring our function so that we can return back to the things that we enjoy, whether it's going back to work, going back to sport, enjoying retirement, or other activities like traveling. So we do look at improving your cardiovascular fitness. That's what we know exercise can improve: your muscular strength, your bone health, your mental health, your mood, as well as reducing the risk of comorbidities, which both Trish and Therese have touched on. Is that unfortunately, when we've gone through chemotherapy and other treatments and a stem cell transplant, we are at risk of other comorbidities. And we know that exercise has a preventative effect. And so that's what we try to address. I know a lot of you still experience fatigue, especially after transplant, and it can last for months or years after. But one thing we know is that exercise is one of the best things that we can do to help mitigate the side effects of treatment with fatigue. Obviously, it is multifactorial and there's multiple reasons why fatigue may be continuing. However, one of the proposed mechanisms is around mitochondrial dysfunction. If you've had corticosteroids, if you've downregulated your physical activity, mitochondrial dysfunction can be quite prevalent. And so we know that aerobic exercise is one of the best things to help restore our mitochondrial function. And we know that when it comes to exercise, we can do both aerobic and resistance. Resistance exercise can improve your fatigue, but at the same time, it's not as beneficial as aerobic. Now, I would highly recommend, if you haven't already, there's a fabulous presentation already presented from Morgan Atkinson's, I think his name is, who did a presentation for the Leukemia Foundation specifically on fatigue. And I'd recommend that you go back through that, as it is very insightful and informative as well. But I will be addressing other issues that people have faced during treatment as well. So when we look at exercise, the therapeutic benefits, we do look at its prescription. And that's where exercise can be seen as medicine. We look at the dose, the frequency, the intensity, as well as the type and duration in which we exercise. So when we look at the different components of fitness and health, what we're looking at is your cardiovascular fitness, your muscular strength, your muscular endurance, your flexibility, but also your body composition. Now, your body composition is what makes up the body, whether it's your fat mass, your muscle mass, your bone mineral density, as well as your organ weight. But specifically for this presentation, I'll be focusing on your bone mineral density. So today we'll also talk about the recommendations when it comes to exercise. So the general recommendation for most individuals, for older adults, is that we need to be achieving 150 minutes of aerobic exercise each week. This can be accumulative over the week. You can do 10-minute bouts throughout the day, or you can do five 30-minute sessions each week. But it obviously depends on where you're coming from as well. If you're not used to exercise, we recommend that it's gradual, it's progressive, so that you can achieve that. And that's where we see those benefits are evolving, is around that 150 minutes per week. and that's post treatment. There's different intensities that we should be exercising at as well. When it comes to if you're not used to exercise, it might be more around that low intensity. Then we gradually build up to moderate intensity. And then we can look at vigorous intensity once we're actually able to achieve that 150 minutes and we've got a solid foundation of fitness as well. Now, when we look at intensity, how do we monitor it? There's different ways that we can monitor intensity. The main ones we look at is a scale called the rating of perceived exertion, which you can see on the left-hand side. And so we ask people out of 10, how hard do you feel that you're exercising? And that gives us a good indication of how hard that person's exercising. And we ideally want them to be between that 3 to 5 range. But obviously there's other ways of assessing through a talk test, using your heart rate, but we also use your symptoms as a way to help guide us as well. Now, when we look at strength training is where you help to rebuild your muscle strength, your endurance, and your capacity to do activities daily living. And this is where we want to focus on a global approach. So that's using the major muscle groups in your body, your chest, your back, your legs, and even your core. You'll find that corticosteroids and chemotherapy itself can affect your muscle mass, and that's all over. That includes your pelvic floor, your feet muscles. And so not only do we want to look at those major muscle groups, but we also want you to be aware of how to activate your pelvic floor and how to help strengthen those foot muscles to prevent any issues such as plantar fasciitis down the track. But when we look at the general recommendations, we do encourage the 2 to 3 times per week at a moderate intensity. You can build up to vigorous, which looks a little bit more of strength training. But when we're looking at intensity, if we go just back to monitoring, still that 3 to 5 range that we want. But when you're actually performing your set of in that exercise, so how many reps that you can do in that set, you really want to have about 2 to 3 left in the bank before you start progressing. If you feel like you can do more than 2 to 5, it means that you should actually be progressing. And if you can't do more than 2 to 3 left in the bank, then it's saying that it's too hard. So it's saying we need to probably reduce whether the reps or the weight with that. Now, impact exercise is crucial when we're looking at helping our bone health. However, we want to make sure that it's progressive and it's implemented at a stage that is safe. We generally ensure that people have a foundation of strength before we actually start impact exercise. So it usually happens around 12 to 24 months or a little bit beyond. And we know that it does help with rebuilding that bone strength. People who should do impact exercise are those who are at a lower to moderate risk of fracture, and that's when you're looking at your bone mineral density and your T-scores. What you'll find is people who have osteoporosis or those who have lytic lesions, impact exercise is not recommended, but we can still do other exercises like resistance exercise, which can benefit you for your bones. So that's why we generally recommend we should do both resistance and impact to have a strength of that bone, strengthening the bones, but we can just use strength if we need to as well. The recommendation, so obviously it has to be progressive in nature. Safety is crucial and is priority. So we want to gradually start slowly and build up. And the recommendation is when we can start implementing impact exercise is that we should be doing a total of 50 hops or jumps. And we want to be doing that with breaks in between those. So you might be doing 10, have 1 to 2 minutes rest and do it again, because the rest is where the bones actually start adapting to the stress and then it gets stronger. But please remember that the impact exercise is only for individuals when they're ready. Please don't start it just straight away, and it should be under supervision to ensure that it's safe. So physiotherapists, exercise physiologists will generally do assessments to ensure that you can safely start this type of exercise. We also integrate stretching exercises into program to make it holistic as well. So it helps to improving your posture. It can help reduce stress and tension in the body. And it can also help improve range of motion. So people who experience stiff and tight joints, stretching is very valuable. You can do it every single day because it feels good as well, but generally 2 to 3 times per week is sufficient. And how strong should you actually stretch? Now, when it comes to the level of intensity, if you have your finger out and you gently pull it back, you'll feel a gentle stretch. That's the level of intensity we really want to do. If you sort of pull it back really hard, you'll find that it's quite uncomfortable and painful, and that tells you that's too strong. So if you apply that to other larger muscle groups, if you do it too strong, the muscle will actually contract, and you're not actually going to benefit from that stretch. It's just going to probably get a little bit tighter. So always listen to your body and ease into a stretch. And we avoid that sort of ballistic movements, which is quickly moving in and out of the stretch. It should be slow and controlled and held for about 10 to 30 seconds, depending on exactly what we're trying to achieve. We also integrate what we call as sensory motor training, or it's also known as neuromuscular training, which includes your balance, your coordination. It can help with improving your gait, but also it helps with agility, so about being able to adapt to different situations. Obviously, safety is key. And what we have seen is when people have symptoms such as peripheral neuropathy, which is very common for people with multiple myeloma after an autologous transplant, we find that if we integrate sensory motor exercises, it can help with the severity of symptoms. An example of this is when we had a client, she came in, she was experiencing peripheral neuropathy in her feet. We did some balance exercises, but also used spiky balls on the base of her foot. We started only with a couple of seconds, about 30 seconds, and we wanted her to do that for a week, and we wanted to reassess. And surprisingly, she got a massive improvement, about 60% she reported. But please know this doesn't always happen for everyone. Everyone's different. The reasons why peripheral neuropathy on the severity occurs, you'll find, is multifactorial. So we really want to make sure that our programs are individualized for you and making sure that they are adaptive based on your symptoms. So when we're looking at recovery, everyone's journey is unique. And when we're looking at exercise priorities, we really want to be ensuring that we consider your age, your medical history, as well as your goals and what your functional capacity is. And so that's where it's really important that you are guided by someone who has experience in this space. There are precautions when it comes to exercise. So if you have peripheral neuropathy, we do encourage that we're looking at balance, sensory motor training, and aerobic exercise, as we've seen that's beneficial because there's obviously a risk of falls, and we really want to make sure that safety is priority. So making sure whenever we're integrating any balance or sensory motor, you're near a stable surface. We're looking at corticosteroid use as well. That's predominantly used with all treatments, allogeneics and autologous transplants. And it does increase the risk of avascular necrosis, osteoporosis, increased risk of diabetes, as well as weight gain. And so we're looking at those factors and factoring that into this prescription to reduce the risk of those things occurring or to managing it. We're also, for individuals who are on maintenance treatment, like lithidomide, there is considerations around your exercise because the exercise recovery is a little bit delayed, and because it's the actual medication itself reduces the blood flow slightly to certain areas. And so it may mean that once you've done an exercise session, you may be a little bit more sore, and that's where we might need to taper back your prescription slightly. And that's where it's important that you are guided by someone so they can adapt. Other precautions is around if there's lytic lesions because of the risk of pathological fractures. So obviously we look at ensuring that the exercises are implemented gradually, and we're making sure that you're not experiencing any adverse reactions as you exercise. The other safety precaution is around infection risk, which you've been informed about quite extensively through our presentation, but making sure that you practice good hand and equipment hygiene, and you're in a space that's safe as well. So when we're looking at exercise considerations, I really want to bring your attention to making sure that you inform your treating team, whether it be your transplant team or your GP, that that's something that you want to do. So they can also loop in the appropriate individuals. Be aware of what your blood counts are. So that's important, as that could be a reason why exercise may be delayed or adjusted. Your bone mineral density is always important to know. That might be something that you find out usually around the 12 or 24 month mark. But before you go through transplant, you would generally go through a DEXA scan to see where you're currently at as well. So all of this information will help to actually prescribe a program. But the most important thing is obviously listen to your body when you are exercising. When it comes to GVH, there are considerations, especially when you have skin, musculoskeletal, and joint GVH, as well as pulmonary. And so we really want to adapt the program to address this. Now, the research in the space around exercise for GVH is evolving. Some are real preclinical trials, and there's a couple that are starting. So it'll be really interesting to see what comes out, but what's important is the program has to be tailored to your individual needs. And so as you can see, based on where GVH is popping up, we can actually then adjust your program to support that. When not to exercise, this is super important, especially when there are specific guidelines from ACSM, which is the governing body for exercise prescription in America. There are also ones in Australia, but ACSM is where they generally come from. That is on the next slide, but I won't specifically go too much in depth in that. But for this particular slide, I really want to highlight that you don't want to exercise when you do have flu-like symptoms. And if you're actually physically unwell, like vomiting or diarrhea, exercise, probably skip that day. And also with your blood counts as well. So you should generally be your blood counts should generally be rising. But for some people who engraftment might be a little bit slow, like I did, it was important to know when it was unsafe to exercise because there was risk of potential bleeding or reduced capacity, and also infection risk as well. So they're the contraindications from ACSM. You can have just a quick read, but if you would like slides to go through this a little bit more, I am happy to share as well. So you can shoot me through an email or ask Linda as well. When it comes to motivation, obviously fatigue is one of the things that really likes to dampen down motivation. So it's important to have strategies to help improve your adherence to exercise. Things like knowing why you want to do it. So it gives you that fire in your belly. So you know what you want to do, and it actually helps you to stick to it. Making sure you have goals. Exercising with someone's really important, or whether it be a friend, a family member, or seeking support from a professional. But also you've got really great devices out there, like you've got Whoops, you've got Fitbits, you've got Apple Watches, Garmin's. They can help track your steps and also your heart rate. So you know that you're exercising at a safe level, and you can also track your progress. You can keep a calendar or a diary to keep record of what you're doing. And also if you have a prescribed program, is really helpful to follow that as well. So it takes out that guesswork of what should you actually do and what's safe. One strategy I found which was really helpful is called the 5, 4, 3, 2, 1 rule, which is when you count back from 5 to 1, and as soon as you get to 1, you just get up and do it. we can tend to postpone exercise. We tend to, other things pop up, but if we know that we've got a set time, just, I would say, try and get up and do it when you can. So a little bit about an example for my first 12 months post-transplant. So my goals were to be able to walk my dog. Why? Is because I love her, she loves walks, and I like making her happy. So that was one of my goals, was to be able to take her for a walk. The other one was also for my up to 12 months, was I wanted to get back to work and I wanted to be able to run 10Ks. Now, the considerations around that obviously was the delay in my red blood cells coming in. So I was transfused every 7 to 14 days because they were quite low. And so I did have to adapt my program based on that. There was also always sometimes setbacks, which is important to recognize. So I had my CMV was reactivated. I got sick after going to a friend's wedding, and that sort of postponed a few things. But making sure that the program that I had was adaptable and it was periodized. So I gradually built up things. I snacked on exercises, which meant I might have done a few kitchen bench push-ups. I might have done a couple of sit-to-stands, depending on how I felt throughout the day. On other days, I might have been able to do the whole thing at the same time. So it's really important that you do listen to yourself and gain that support when you need as well. So how to access services. So there are some financial support which you can access through your GP. They can write up an enhanced primary care plan for you, which gives you up to 5 sessions to see a physio or an EP or other allied health professionals like a dietitian. There's also programs in the hospital or even privately as well. And there are some really good student-led clinics in the universities available as well. Like at the University of Canberra, where I'm from, we have one. I know Flinders has one. There's one in Western Australia, and I believe there's also one in Victoria as well. So to see where those programs are, you can access it through ESSA. You can also find it through the Physiotherapy Association, but also the Leukemia Foundation does have a service directory as well. So definitely check that out to find where your nearest person is. And there's also some great resources through Exercise Right, and it can go through the benefits of exercise for other comorbidities which clients can present with as well. So just to summarize, I'm just being mindful of time. It's the take-home message is realizing that recovery is individualized to each person. We really want to restore our function, and that's where that collaborative care from exercise, nutrition, as well as psychological support is really beneficial. It helps to reduce symptoms, side effects, but also improve our quality of life. Now, when we also look at it's making sure that's really important as well, is make sure that we're not comparing ourselves to anyone else. And I would also recommend avoid comparing yourself to pre-transplant as well. Give yourself a clean slate and allow yourself to actually go through the recovery process with as little expectation as possible, just because you'll find that there are setbacks at times. And so you want to make sure that you are guided through those processes and keep taking steps forward, but realize occasionally there are steps backwards and sideways as well. And so that's just my contact details. If you would like to shoot me through an email, happy for you to reach out as well. So thank you very much, and I hope the presentation was helpful. I'll just finalize. There we go.
Thanks so much, Mel, and Teresa and Trish. It was an incredible amount of information, recognising that there were some very specific information to the particular transplants, but also lots of crossover and lots of commonalities in the experience. Hey, Mel, I really like the concept of exercise snacks. Exercise in bite-sized pieces. I think it makes exercise so much more accessible for people to do when you think about it like that. So thank you for that. useful for me. I'm going to circle back to Teresa. You mentioned in your talk about survivorship care plans. I'm wondering for the audience, how would one go about having a survivorship care plan set up?
So the survivorship care plan, so when a person's referred to our long-term follow-up clinic, like I've mentioned earlier, we do a whole system approach. So we look at not just the blood tests, not just we looked at the physical and the psychosocial side effects. So that care plan is a 5-page care plan. So I've only shown you the front bit because it's 5 pages. So after the consultation, depending on the prior treatment, the exposure to chemotherapy, radiotherapy, we create like a care plan as to how we can address, one, the goals that they've achieved, two, the concerns that they have when they come into clinic, and if we've noticed anything in their investigation results or blood results that we wanted to follow up, that's what we put on the care plan. Once that's been done and the consultation is finished, we summarize all of it and then send it to the patient, their GP, their referring clinicians, and to whoever specialist that they want us to send it to. So that care plan is accessible once they've come to our clinic. But I also know that some GPs do like a chronic disease management care plan, which is slightly different to ours because ours is focused on the whole treatment that the person has experienced from diagnosis to transplant and after transplant.
Lovely. Thanks, Teresa.
Thanks.
If one perhaps doesn't have access to the resource of Peter McCallum, for example, would it be reasonable for someone to ask their treating team for some type of care plan equivalent to a survivorship care plan?
Yes, absolutely. Yeah, absolutely. And I know that Trish and the myeloma team are trying to, formulate that as well. Yes, that is possible. Speak to your treating team and just say summary of, the treatments that I've had. It might not be as, as like a summary like what we do, but obviously it will give them obviously the information from when their diagnosis was, what treatments did they receive, and because of these treatments, what are the things that we need to watch out for or that we need to monitor. So yes, is the answer to that question. Yeah.
Lovely. Thanks, Teresa. I think this probably is then a lovely segue into this next question. And, this is really open to any of you to respond to. But I guess one of the challenges is around transitioning from that very intensive treatment and support into that recovery, rehabilitation, and long-term care and support. And a very strong relationship forms with those treating teams and patients. How do you help prepare people to make that transition away from their treating team and to those local community supports? Teresa, Trish, Mel, any of you have any thoughts around that?
I think that's a really great question because I have experienced that from one of the patients that say, oh, I don't know how I'm going to go back. I think first of all, it's for you to find a really good GP, having a good GP that you can follow through and follow up through. And we always, like I said, when we give out the care plans, we have our contact details there, and we always welcome for the GP or the primary care providers to contact us if they have any questions. Some of the things that needed to be followed up in the community doesn't have to be done. They don't have to come back to the hospital for that. So, and that's why having a really good GP to integrate all of that and to follow up the recommendations that we have and the treating team have is very important. And having that contact detail so that if they wanted to do, they have a question for us. We also sometimes do like a telehealth consultation with the patient and the GP if they want to do that at the first instance. So then we can explain, obviously, that this is what our recommendations would be, and this is why we recommend that and why we follow it up. So yeah, that's my take.
Thanks, Teresa. Did anyone, Trish or Mel, want to add anything to that?
I would just echo that it's really important to have a good GP. because you won't be seeing your treating team as often. It might be, initially it might be every week, twice a week, and then it extends out. So your GP is super important to have.
Yeah, I agree as well, Mel and Teresa. I think it's up to us as well as experts in this area to be able to share our expertise with our GP colleagues so that they're also really informed. And I think the care plan, or whatever you want to call them, a survivorship care plan or a preventative healthcare plan, is a really good model and a really good tool that can actually be the linchpin between your treating centre and your GP. Because, a really well-informed GP is really going to be so important in making sure all of those, preventative healthcare things that we discussed are carried out essentially.
Yeah, great. Couldn't agree more. And I do want to give a little plug. Whilst we haven't formally publicised it yet, we will be running a webinar in May about the role of your GP in blood cancer care. So keep an eye out on our events calendar for that. In terms of recovery expectations, so sometimes we hear patients say, we've been told this is how long it's going to take to recover from my transplant, recognizing that there are many factors that influence that. And then there's also, and I guess so there's a time frame that's often given, and then there's what the reality often is. And often we see with patients this gap between what's expected and the reality of the recovery. Is this something you see in your practice, and how do you go about helping to bridge that gap, the gap of perhaps the clinicians and the recovery time sort of predicted versus what actually happens in reality? Because that can often be quite a struggle and disconnect for people. Happy for from a clinician perspective, or perhaps from a personal perspective too.
I'll just jump in and I'll just say, with regards to expectations, I think obviously there's, when it comes to medical, it's around restoring your blood counts and the reconstitution of your immune system. They're the markers that they generally will look at from a recovery point of view, from a medical standpoint. But obviously there are the other factors around your function and your emotional status as well. And I would say that's where it's really important that there's a proactive approach and that you're addressing those areas to help you in that recovery. So unfortunately, we can't sit and do nothing. We do need to put effort into our recovery, making sure that we can control what we consider as our modifiable factors, and that's around our exercise, our movement, what we eat, as well as making sure that we have the emotional support to help with our recovery as well. And that's how I approach recovery, but that's how I also work with my clients about recovery as well, is ensuring that they have that supportive care. But I'll hand over to Trish or Therese, and I'm sure they'll have recommendations too.
Yeah, thanks, Mel. That's very well said. In my practice, it's very individual, and no two patients' recovery will be similar. And it's about normalizing that for the person that's going through that. Because, okay, I'm a clinician, I've been working in this field for 20 years, I see it all the time, but you're going through it for the very first time. And I think normalizing it, I think what you said, Mel, is really important about controlling what you can control. Sometimes you don't have control over your blood count. You don't have control over, you know, perhaps getting a significant infection that might have bounced yourself back into hospital. These things happen, but do control what you can, and that's important to focus on. And I think what you said in your presentation as Mel was a real pearl for me to take away, was about setting yourself small expectations, or not having huge expectations, and setting yourself small goals that are achievable goals, because we all feel better when we can, you know, tick those off at the end of the day.
Yeah.
But I really like that piece, Mel, you mentioned about expectations and not having, huge expectations. Yeah.
I couldn't agree more to Mel and Trish. Like same with Trish, Mel. I really love the idea of having smart goals, and that's why in part of our clinic we encourage our patients to have goals that they wanted to achieve, like in within 6 months and in a year. Everyone is so individualized, so everyone has a different time to recovery. Everyone has a different response to that. I've seen someone in clinic who's had a transplant when he was a child, and he's still having, you know, physically he's fine, but still struggling a little bit in terms of adjusting. So it does take time, and this is why I see the value of having seeing them and reassuring them and trying to assist them in navigating those areas that they find challenging in terms of the recovery. And it can take, I agree, it can take months to years to completely recover post-transplant. Yeah.
Lovely. Thanks, Trish, Teresa and Mel. I probably, in the interest of time, we do need to bring it to a close, but I do want to acknowledge Dallas in the chat, who has also just said that he is someone who lives remote and just working out he's in the process of working out about survival and the new normal. And I think, Teresa, you just touched on that adjustment piece, and love to dive into that more, and maybe that's certainly for another day. But on that note, I will hand back over to Jen to close us out.
Thank you, everyone, for sharing your skills and knowledge and your thoughtful, informative conversation with us today. And I think we've covered a huge range of issues related to recovery and transplant. I think it's a reminder to everyone out there that we have a lot of webinars on our website that do dive a bit more deeply into a lot of these topics. So remember, there's some great resources there. And for any other further questions or concerns, call us 1-800-620-420, because help is only a phone call away. And then you've got access to all of these gorgeous people. A little brief survey will be coming your way. We'd love to hear your thoughts. We really do shape our program about what you tell us you need. And keep an eye out for the May webinar on how to work with your GP once you reach that more long-term survivorship phase. Thank you, everybody here today, and for everyone who's joined us. It's been a pleasure. Bye-bye.